Good morning to all of you. A warm welcome to all the delegates and the guest speakers from outside the country. And as we are already late, we'll start the symposium on innovations in PCI. First, I invite Dr. Martin Leon to deliver his talk on drug-eluting stents in 2012, lessons learned over the last decade regarding the safety and efficacy. Dr. Martin Leon. Actually, in fact, Dr. Martin Leon doesn't need any introduction to this gathering because he has been already a part and parcel of all this. Last year also with his support, and now with active support from Dr. Martin Leon and Dr. Srinivas Kumar and Sushil Kodali, this is happening. Though there are several people also contributed, but these are the main people who are behind this conference to happen. Dr. Martin Leon is the director, Center for Interventional Vascular Therapy, Columbia University Medical Center, New York Presbyterian Hospital. He is the course director for TCT conference. He is the founder director, CRF. Dr. Martin Leon, please.
Thank you very much. It really is a pleasure to be here. I've had an opportunity now to spend a few days in India, and it's been a wonderful experience visiting with friends, learning more about the culture, and certainly benefiting from some of the fine food and wonderful relationships that I think are developing between our group in New York in the United States and my wonderful friends and respected colleagues in India. So it's a pleasure to be here. I want to thank Srinivas Kumar and Sushil Kodali for their special efforts in putting this program together. And I'm excited about the idea of helping to build what is a very important educational effort in the center of India and to participate again with such a fine faculty. This first lecture really is an opportunity to look back and to share some observations and experiences that we've had over the past 10 or more years with drug-eluting stents. These are my disclosures. And I'll start by confessing that my first trip to India many years ago was the occasion of the 1 millionth implantation of a Palmaz-Schatz coronary stent in Madras. And I was struck at that time by the enthusiasm of the physicians and the patients with this exciting technology. So of course that was a bare metal stent, and you ask yourself, well, why did we evolve to drug-eluting stents? And this in fact was that bare metal stent, the Palmaz-Schatz tubular slotted stent with a central articulating bridge, which you can see here. And the first randomized trial, meaningful randomized trial in the bare metal stent era was the Benestent trial. And here you see a randomized trial comparing bare metal stents versus balloons, and they demonstrated a statistically significant reduction in restenosis from 32 to 22%. We in the United States were doing similar studies, the stress trials, very similar design, and we also demonstrated a significant reduction in restenosis to 30% from 45% with balloons. But still 22, 30% in simple or intermediate complex lesions was not a very good restenosis rate. So even though we had achieved some success, the main reason why bare metal stents became important at that time was that they improved procedural safety. They achieved predictable angiographic results, and yes, they reduced restenosis, but still there was significant restenosis. So bare metal stents were successful. I think they helped interventional cardiology move into a more predictable era, but still restenosis was very problematic. We understood the reason. It was a combination of elastic recoil and intimal hyperplasia with balloon angioplasty, but with stents, it really was neo-intimal hyperplasia. So we reasoned if we could combine an effective anti-proliferative agent with a fixed metal scaffold, it could solve the problem of restenosis. So this was the early days of drug-eluting stents. I'm showing you a picture with the first follow-up of the initial implantation of the Cypher stent that began in December of 1999 after they had done angiograms in 15 consecutive patients And one after another, they found these results. No change in the stent site with almost no late loss and zero restenosis. This followed many clinical trials demonstrating that this truly was a transforming technology. And Patrick Sarai said that his rosy prophecy was that restenosis would be cured. There were two versions of the early drug-eluting stents, of course, the Cypher and Taxus, different drugs, different durable polymers, different stent platforms. This is a manuscript that we published in New England Journal of Medicine combining all the randomized trials from Cypher and Taxus showing that compared to control, bare metal stents, that there was no difference in all-cause mortality, but a dramatic reduction in ischemic target lesion revascularization, a dramatic improvement in restenosis. But those were randomized trials. When we took this out to the community, to real-world patients, we also found an 86% reduction in in-stent restenosis cases with the Cypher stent. Large studies began. This is the first collaborative network meta-analysis by Stetler that was published in The Lancet in 2007. In over 18,000 patients, there was no difference in mortality compared to bare metal stents, but again, a dramatic reduction in target lesion revascularization. So the penetration of drug-eluting stents increased. It increased very dramatically. Within a period of a few years, 90% of the stents implanted in the United States were now drug-eluting stents. And in Europe, within a matter of a few years, there suddenly were 22 CE-approved drug-eluting stents, and I'm sure in India you saw many different versions of drug-eluting stents. So these were the early days. We learned many lessons. The impression was that DES solved restenosis. The pivotal data looked very good, both safety and efficacy, and people thought that maybe they're good for all lesion types and in all patients. So there was tremendous excitement and enthusiasm with a very high penetration rate in certain areas such as the US where reimbursement was assured. But suddenly things changed and DES were cast into crisis. There was a 4-patient review in Lancet in 2004 for the first time describing a phenomenon of very late stent thrombosis after discontinuation of antiplatelet therapy. In real-world scenarios, such as a registry from Bern and Rotterdam, there was a marked increase in the frequency of stent thrombosis, and stent thrombosis continued after 1 year, this phenomenon of very late stent thrombosis. And suddenly, in the summer of 2006, there was an analysis of randomized trials suggesting that there was actually an increase in death NMI with drug-eluting versus bare metal stents, and this was the so-called ESC firestorm. At the same time, there was a large country registry from Sweden called SCAR indicating that mortality may be increased with drug-eluting stents in this landmark analysis after 6 months. So suddenly, there were major safety issues. We call this the SCAR scare, and in lay publications such as this one, DES were characterized as 1 million ticking time bombs. So DES were in crisis, and we began to talk about not the benefits of DES from the standpoint of restenosis, but some of the serious problems that relate to delayed healing, inflammation, abnormal vasomotion, incomplete apposition, and this phenomenon of very late stent thrombosis. So now the penetration rate of drug-eluting stent decreases in the US from 90% all the way down to in the mid-60% range, as you see here, very quickly. So now these were the dark days of drug-eluting stent, and they were probably underused. DES was associated with increased thrombosis. Some people felt that it caused an increase in mortality. At the same time, the COURAGE trial suggested that medical therapy was an acceptable alternative, and many people felt that DES use should be dramatically reduced. So the next phase is what I call DES recovery. It took a great deal of work. This is additional data from the SCAR registry, 1 more year, 15,500 patients, and suddenly, with the same landmark analysis, after 6 months, there was no difference in mortality. So the SCAR scare became the OOPS from Uppsala. There were over 2,500 peer-reviewed manuscripts on DES clinical use within a short period of time, trying to describe safety and efficacy events. This is one that was published by my colleague Ajay Kirtane in Circulation in 2009, which is what we call a mega-meta-analysis. This is an analysis that really looked at 56 studies, both randomized controlled trial data and registry data associated with drug-eluting stents, to try to understand if there really were safety issues. If we look at all the randomized controlled trial data, looking at all-cause mortality, there was no difference between drug-eluting and bare metal stents and mortality. If we look at the registry data, if anything, mortality was lower with drug-eluting stents. If you look at MIs, same thing. No difference in the randomized data, and in the registries, at least a suggestion that there may even be fewer associated MIs with drug-eluting stents. So if we look at the treatment effects, there's a consistent reduction in target vessel revascularization in both the randomized trials and the registries of about 50%. Certainly no significant safety issue looking at this very large mega-meta-analysis. At the same time, we realized that drug-eluting stents really should not be characterized as a class, that each one was uniquely different, and because they are different, they have to be studied individually. And next-generation drug-eluting stents were now being introduced to the market. So we have things like Xience V and Resolute, and these were quite different. They were designed specifically for safety and other characteristics that hopefully would improve clinical outcomes, lower drug doses, safer, more biocompatible polymers, more deliverable stent platforms. And in this analysis done by Greg Stone, looking at the combination of the SPIRIT and COMPARE randomized trials, you can see second generation everolimus-eluting stent, Xience, compared to first generation paclitaxel-eluting stent, Taxus, a significant reduction in ischemic target lesion revascularization, and an equally significant reduction in stent thrombosis, both early and late, suggesting that now the new generation devices are both safer and potentially more effective. Similar with Resolute. In this analysis, looking at Xience versus Resolute, published in 2 parts in the New England Journal of Medicine and Lancet, there was no difference in target lesion failure between Resolute and Xience, and no difference in any of the other safety and efficacy analyses. So we're now at a stage of trying to return DES to normalcy, where the overall penetration rate, for instance, in the United States is about 75%. We know that PCI is better to relieve symptoms and symptoms of ischemia and objective evidence of ischemia. We know that DES really doesn't increase mortality or MI, either on or off-label use, and certainly reduces target vessel revascularization, so we're more confident in using DES, but now with the caveat, careful dual antiplatelet therapy use. So we're left with decisions that we have to make now about when to use bare metal stents versus drug-eluting stents, and I'll try to quickly give you at least a recipe for how we do this. There remains dramatic international variation in DES use. You can see in this publication from the American Heart Journal in 2009 that from country to country, the penetration rate of DES is vastly different. The reasons for variation are largely economic, reimbursement, and cultural sociologic considerations. In this analysis we did in the Asia-Pacific Rim, just this past year, the average DES penetration was about 70%, pretty similar to the US, but the country-to-country variation is dramatic. In India, 62.8%. South Korea, 95%. China, 91%. Singapore, 40%. Still tremendous variation country to country. So what we're seeing is that the United States is fairly stable. We're seeing very little growth in coronary PCI. The DES penetration rate has been very stable. Prices are decreasing, certainly, but internationally, there is some continued growth in PCI, and DES penetration is increasing from what used to be in the 50% range to the 60s and close to 70%, and even higher in certain parts of the world. So should we use DES in all patients? Well, the argument that would say yes is that the randomized control data and the observational data have shown that we can consistently reduce angiographic and clinical restenosis rates, and these benefits are consistent across virtually all patient subgroups. Contemporary data suggests there's no excess mortality or stent thrombosis penalty with DES as long as you apply careful dual antiplatelet therapy. These are mainly efficacy issues that would cause you to want to use DES. Then the con argument would be cost is a consideration. In most parts of the world, DES are at least $800 more than bare metal stents. There are legitimate safety concerns early and late of stopping dual antiplatelet therapy. There's a cost associated with extended dual antiplatelet therapy, and there's a clinical burden of extended dual antiplatelet therapy that may be associated with increased bleeding, worry, and unplanned surgery. So the reasons against using DES universally are cost and safety issues. These are interesting data from the Prodigy trial that were published and presented last year at ESC showing that 6 versus 24 months of dual antiplatelet therapy is associated with a twofold difference in overall bleeding, significant bleeding complications, and this is a linear increase in bleeding, so it doesn't flatten after 1 year. It is a continuous hazard over the course of therapy. So you have to look in making a decision about DES on patient factors and lesion factors. Certainly diabetes is a big consideration, especially in a country like India. Acute coronary syndromes, especially STEMI, is an important consideration. And then dual antiplatelet therapy related issues are the other major patient factor. With dual antiplatelet therapy, you have to be concerned about compliance with the drugs, the risk of bleeding, if the patient's on Coumadin in elderly patients, and the need for elective surgery. We've known for a long time that restenosis in diabetics is much greater than in non-diabetics. This seems to be a population that is well suited to drug-eluting stents, and there's good data, this is recent data from the Resolute studies, indicating that in diabetics the results are extremely effective in reducing target lesion revascularization and cumulative safety endpoints. In fact, non-insulin requiring diabetics, very similar to non-diabetics. AMI is another interesting situation where, for many reasons, the drug, the polymer, the procedure, and the patient may not be a good situation for drug-eluting stents. In this meta-analysis published by one of our former fellows, Sam Brar, he analyzed this very carefully. There was no difference in mortality with DES and AMI. There was a significant reduction in target vessel revascularization, no difference in stent thrombosis, and the benefit is related to the baseline risk. Higher risk for TVR, preferentially should use DES, and that was shown again in the large randomized trial Horizons, where about a 4% ischemic TLR difference expressed itself in the high restenosis risk patients, those with long lesions, small vessels, and in the insulin-requiring diabetics. If you look at the European guidelines on myocardial revascularization, the relative contraindications to DES use all relate to patient-related factors. Poor compliance, non-elective surgery, increased risk of bleeding, and other considerations with dual antiplatelet therapy. But you also have to be concerned about lesion factors. We've known for a long time that restenosis is associated with specific lesion factors, particularly long lesion length and small vessel size. These are data from the Taxis trial clearly demonstrating much higher restenosis rates in patients with longer lesions, smaller vessels, suppressed with a drug-eluting stent. So clearly, as in the Indian population where there are so many diabetics and there's so much diffuse disease, including CTOs, DES should be preferred. Small vessels, DES have a greater effect. Osteolesions, bifurcations, in-stent restenosis, which is diffuse, and vein grafts may also benefit from DES. And also lesions that have high restenosis consequences, like left main disease, proximal LADs, or sole remaining vessels. So, to decide whether to use a DES or a bare metal stent, after all of this work now with so many publications and so much clinical experience over a 15-year period, the first thing you need to do is to examine patient factors. Is the patient a diabetic? Under those circumstances, you would favor using DES. Is it a STEMI or ACS? I think under those circumstances, DES use should be more selective based upon both patient and lesion factors. You have to consider prolonged dual antiplatelet therapy and the safety concerns, and if that is a major issue, you would favor more bare metal stents. Then you have to look at the lesion. If it's a high restenosis risk lesion, favor DES, and the contrary is also true. If it's a low restenosis lesion, you would use DES more selectively, and if a patient had high restenosis consequences, like a left main, you would certainly want to use DES. There are several caveats. In many patients, multiple factors apply, and you have to use good clinical judgment. Stent design issues are important. Deliverability is an important consideration that may choose you to use DES versus bare metal stents. And patients that come in with stent thrombosis is a special circumstance that favors BMS use. And of course, finally, cost sensitivity is a major driver, favoring bare metal stents in many regions. So we've learned now over 15 years that optimal stent selection, bare metal versus drug-eluting stents, varies widely around the world. It's determined largely by socioeconomic factors and regional perceptions regarding the duration and importance of dual antiplatelet therapy. Beyond the cost and safety factors, both patient and lesion factors affecting restenosis risk should favor more aggressive DES use. Among DES, I think you should strongly favor the current, more modern generation of DES. Future DES, which are being recently introduced to the market, will likely add value. We also will have to consider in the future the potential impact of drug-coated balloons in certain lesion subsets. I would not discount the importance of deliverability in stent selection. Operators develop specific stent preferences based upon experiences. DES should be the default therapy for coronary PCI, which is it should be used preferentially unless you find specific reasons to favor a bare metal stent or no stent at all. And never underestimate the potential impact of important new and unexpected data. So a study like FAME comes along, and now we have to challenge whether or not to use stents at all in so-called intermediate lesions that are non-ischemia producing. A recent meta-analysis performed in The Lancet looking at many of the drug-eluting and bare metal stents, 49 studies in over 50,000 patients, suggested that some of the new generation drug-eluting stents with fluoropolymers may in fact be safer than bare metal stents from the standpoint of stent thrombosis. So you have to integrate some of these new data. And right now it truly is a balance to maximize the benefit-risk ratio, which is largely in favor of DES under most circumstances. And I would predict in the future, as technology continues, as pharmacology gets better, and as we become more experienced and prices decline so that reimbursement is not much of a consideration, that under most circumstances, DES will be the default therapy for the vast majority of patients with ischemic obstructive coronary disease. Thank you.
Thank you very much, sir, for enlightening us about the evolution of the stents and the present status of drug-eluting versus bare metal stents, and also enlightening us about the patient factors, lesion factors, and comorbid conditions. Thank you very much, sir.